Thank you, Dr. Trotty. It's my pleasure to introduce Dr. Marie Morse, who is a board-certified adult neurologist with special qualifications in child neurology and sleep medicine. She's the director of the Child Neurology and Pediatric Sleep Medicine at Janet Weiss Children's Hospital. That's in the Geisinger Health System, Pennsylvania. And Dr. Morse is recognized as a key opinion leader in sleep medicine, especially with regards to central disorders of hypersomnolence, such as narcolepsy. She has proudly embraced a reputation as a healthcare disruptor, challenging the current delivery of care, embracing digital transformation, and advocating for delivery of care that is through partnership with the patient and community, personalizing their wellness journey to their individual needs. And as a result, Dr. Morse is a highly regarded advisor for multiple advocacy organizations, startup companies, and well-established industry partners. Welcome, Dr. Morse.
Wonderful. Claire was upset with me because I refused to send her a bio. I was like, I really hate these eulogies that I get at the beginning of a talk. I'm Marie Morse. I'm really excited to be here and really interested to hear from you on this topic. So I'm going to talk about brain fog. However, many of you in this audience are the people who are the most expert on this topic, because we don't even have a definition for it, which we'll go over today. But I'm going to attempt to really characterize what the experience might be and what are some future directions that we may be able to go in to better understand what this condition is, as well as how we might be able to improve the lives of those living with it. So we're going to talk about brain fog and really propose the question, is this a core feature of idiopathic hypersomnia? So the agenda for today, what are we going to talk about? What you're seeing in the blue boxes is the topics, and then what you're seeing on the gray side is the questions that I want you to think about as a person who may be living with IH, a person who may be living with brain fog, a family member or a support person of someone who is living with IH and may be experiencing brain fog. The commonly described core features of idiopathic hypersomnia. What's missing when I describe that? Characterize what a person living with IH might look like. Do you see your own reflection in this? In a loved one? Defining brain fog. Is it as clear as mud? Probably. Defining what brain function is. When I characterize this component of it, you're going to be able to see why brain fog is such a difficult consideration to define. And I want you to start thinking about, as I go through these different spheres of brain function, where you may fall in that and what may be contributing factors to the experience you may be having. We'll then talk about brain fog specifically in IH and what we know about it, and then talk about the therapeutic considerations, some food for thought and personalizing your recipe for your own success. So living with idiopathic hypersomnia, I'm beating a dead horse and talking about these core symptoms that we describe. However, these fail to actually define the symptoms and the experiences that I hear on a daily basis. When we talk about excessive daytime sleepiness and sleep inertia, those are fine medical terms, but the things that I hear from patients are, I can't get out of bed, I can't shower. Thinking about grocery shopping, who has time for that? The thought is painful to me. Nowhere in this description of what the core features are truly give a characterization of the burden of this experience. Now, what you don't see on this slide is brain fog. What a person who with IH might look like based on some analyses, and might be a little bit small, but what you're looking here is really a characterization of young adults with IH and saying, what are the symptoms? What are the other things that may be present? The reason for this slide is because it's starting to capture what the core symptoms on the prior slide didn't. So it's demonstrating that these are individuals where their age of symptom onset was more in the teen years. However, their time to diagnosis was around 25 was when they got diagnosed, so around 10 years. What's not characterized in the core features of that disease is what is the burden and implications that occur when there's a delay in diagnosis. There are key elements when I am an adolescent and I have developed symptoms like this. What do you think my academic success is going to look like? It's going to be suboptimal. we're already starting to lay foundational elements to why my cognitive function may not be as optimal as someone else my age, or what my cognitive function should be based on the trajectory of what my own IQ is capable of. I'm missing out on these very, very critical moments. Some other pieces that Dr. Trotty had alluded to is looking at the medications. And you see the same type of distribution as she described of individuals who are choosing to be on no medication versus there are many who are requiring polypharmacy, but yet still inadequately thriving, merely surviving. And when you're looking at how well controlled, you see that it's only the minority who are saying that they feel like they are strongly agreeing. One person, to be exact. In addition to those other features of the core features that were presented on a prior slide, again, what is missing is the overall burden of this condition. And so what you're seeing on the right hand is you're seeing some of the comorbidities that individuals may experience. And some of them may be singular, but many may have multiple comorbidities. The reason I give the illustration around the comorbidities is because in upcoming slides, we're going to be discussing brain fog. Brain fog is not singular or isolated to idiopathic hypersomnia in regards to the conversation around this burdensome symptom. We see it in a variety of disorders where the question that remains to be answered is the lived experience of brain fog in these other conditions the same as what a person who has IH is experiencing? And it may or may not be. And so if there is brain fog that can occur when I also have depression, and it is a distinct brain fog from what IH is, and I have both, I have two types of brain fog, making it very unclear. When you're looking at the symptoms experienced as well, you can see that these symptoms are incredibly burdensome. So when you're looking in the bottom right-hand corner, we're talking about the symptoms that very frequently we're saying are the core symptoms of idiopathic hypersomnia, but it also is inclusive of brain fog. And you see that when you're asking an individual if you've ever experienced these symptoms, and then what if you've experienced them in the last week, you see that excessive daytime sleepiness and brain fog are both the most prevalent symptoms experienced. It also means that these individuals are viewing them as two distinct things. However, they are likely also related in that if I have a cognitive disability and I superimpose another brain insult, it is going to make that cognitive disability even more enhanced. So by having excessive daytime sleepiness in addition to brain fog, your brain fog will be exacerbated. So how does this actually show up in life? So yes, we have all of these beautiful scales like the Epworth Sleepiness Scale and Idiopathic Hypersomnia Severity Scale. However, they fail to inform on what the lived experience actually feels like, the disability that actually occurs when living with this. There's a beautiful word cloud in the middle, and I don't say it's beautiful because it's saying things that are positive, but I think it's beautiful because it really is providing the words that many of us may feel when we're not able to perform what we know we are capable of. We feel ashamed. We feel stigmatized. We want to hide. It really layers onto the cognitive disability that we're experiencing. It removes the motivation to do better because you know even at my best attempt, it's less than what I know I'm capable of. Another layer that is going to further expose the disability experienced. When you're looking at this, you are seeing some responses from individuals living with idiopathic hypersomnia, asking them specifically around what their stigma may look like and what their ability to do social roles and their functioning may look like. And what you're seeing on the dotted line is what would be considered a quote unquote normal functioning. And I say quote unquote because is there really a normal? My normal at 5 is not the same as when I was 15, and it's definitely not the same as me at 42. But I would say that this is giving you a threshold of people not living with idiopathic hypersomnia. So what you're seeing is that individuals are experiencing a much greater degree of stigma. They're finding it more challenging to live in the social roles that may be assumed for individuals, which again further compounds these symptoms that a person may be experiencing. The expectations that were placed on me at 15 were to show up for high school, get good grades, plan for college. The expectations of me now is to hold a job, parent kids, be a good wife, go grocery shopping, cooking. That's a lot different. And so as we advance in age, we sometimes identify that even without the symptoms changing, the social expectations changing, create the lived experience to be a lot more burdensome, to be a lot more stigmatizing, to be a lot more challenging to function, which will again enhance the vision of what the living with brain fog may look like. So when your day starts like this, and we think about just those core symptoms that we talked about, makes it really hard to want to get out of bed, makes it really hard to function. However, what the core symptoms also aren't considering, in addition to brain fog, is all of these things. A person living with IH not only is experiencing excessive daytime sleepiness and stigma, they may have compromised self-esteem, self-worth, self-value. And a layer on top of the excessive daytime sleepiness is they're going to experience potentially fatigue. And yes, that is a different meaning. Fatigue is not sleepiness, although many people, including in medicine, use them interchangeably. The only thing that resolves sleepiness is sleep. Fatigue is not the propensity to fall asleep or need additional sleep. Fatigue is I have the physical or cognitive capabilities to do something, yet I'm unable to execute on them. And sometimes that can be time mediated. The more I try and do something, the more fatigued I become. There also are going to be comorbidities that may be playing an effect, and then medication and side effects. And someone had asked the question to Dr. Trotty, is there any evaluation as to why people are choosing to discontinue medications? Sometimes it's a matter of the side effects of the medication, a lack of efficacy of the medication. It can be the insurances. It can be a variety of other barriers to access to those medications. But sometimes it's a matter of you're playing the seesaw game. I'm treating one thing to only unveil something else. And it's resulting in me having to choose which best version of me is going to come out and play today. So in a study that was evaluating an attempt to define brain fog, they looked at Reddit, and this is how they had defined it. They said brain fog is describing heterogeneous experiences, including dissociation. So kind of almost like it's not really me, I'm looking at myself separately. Fatigue, forgetfulness, excessive cognitive effort, and an association with a range of illnesses, drugs, and behaviors. It's a very clear definition. I know exactly what brain fog is now. Same? Good. So in a paper that we had published last year, we wanted to better understand brain fog from the capacity of what has been published on it. And as you can see, when you're looking at brain fog, it's not unique to idiopathic hypersomnia. We see it in a variety of conditions. However, one of the commonalities of many of these conditions include that there is an inflammatory component to them, which raises the question of, does inflammation play a role? For me, as a clinician and researcher, I would say I do think that that probably is likely. There's clear evidence that demonstrates that a particular cytokine, IL-6, interleukin-6, can increase the permeability of the blood-brain barrier, which makes me question as to whether or not that may be a contributory factor. Interestingly, IL-6 also is something that can increase your homeostatic drive, your homeostatic sleep drive, your sleep pressure. It makes you want to sleep more. I don't think that's by accident. It might be by design, and it may be relevant. However, when we're looking at these conditions, one of the things that you're going to see is that there are some symptomatic similarities, although there also are a variety of distinctions, such as fluctuation versus there being more persistent chronic symptom experience. But the point of this, again, is saying that an individual who may be living with idiopathic hypersomnia or narcolepsy, for instance, may also be experiencing some of these other things. And so what is the impact of when we're having multiple conditions? A knee-jerk reaction is, well, maybe it has to do with the other treatments, but it may more likely be related to the fact that there's multiple physiologies that are contributing to what the person is experiencing, which may make it more challenging to say there's a singular solution, which is why a part of what we're going to discuss today is what are the personalized strategies that you can employ today to start better defining your lived experience with brain fog. One of the take-home points that you're going to see I close with is a lack of definition does not mean you can't define the burdens and barriers you're experiencing. Use the words you have to better understand your own lived experience and use those as the goals to treat. So why is it so hard to define? Well, number one, what does brain function look like? So this is a simplistic concept that many of us can relate to. And we're thinking about brain function. There's three basic things it has to do. It has to be able to do cognition. Those are my thoughts. Those are going to drive my emotions as well as my actions. So what my affect is and what my behavior is. So it sounds simplistic enough of that if I have brain fog, then I perhaps should have one of these compromised. However, I'm going to take it a step forward and say, first I'll ask a question. How many in this room feel as though that they would be able to define or have an understanding of what cognition is by a raise of hands? Okay, there's some like hands kind of going up. Okay, so when we're talking about cognition, this would be a framework that we may potentially utilize of saying that cognition may be related to social cognition, executive function, memory, attention, and psychomotor speed. In fact, when we look at these areas of cognition, this is very frequently what gets tested when you're utilizing neuropsychological assessments to be able to create frameworks around what is your intellectual quotient or IQ. However, when you're looking at this, you can see that there is a variety of different areas that may actually make it highly variable of how this cognition may look. So even though you may have two individuals who have the same intellectual functioning, they may have strengths and weaknesses around these different domains in a very different distribution. Now, this would give you your first intro as to why it may be so difficult to define brain fog. Because before we can define a pathology, we want to know what the physiology, what the normal looks like. In medical school and in residency and fellowship, they always teach you have to see a lot of normals before you can recognize the abnormal. And so when I'm looking at, okay, well, what contributes to the normals? What contributes to expected function? This is your first part of the framework. However, to layer onto that, as a part of cognition, there has to be knowledge. And so when you're thinking about knowledge, knowledge is not a binary, I have the knowledge or I don't have the knowledge. In medicine, again, we get taught that we have the knowledge or we don't have the knowledge. We are awarded by how many correct answers we can get. However, in life, patients are not multiple choice questions. They are people who are living with conditions. And so when we're looking at knowledge in the context of cognition, there is the knowledge, I have information that is around a certain topic. However, you can see that that knowledge may be applied differently based on the situation. So I may look great in certain contexts. We see this very commonly in our children and adolescents who are living with hypersomnolence disorders, where they put all of their eggs in the basket of academic success. And the school goes, they don't look sick. Why do they need a 504 plan? Why do they need IEP? Why do they need psychoeducational testing? It's because in a situational context, they put all of their effort to retrieve the knowledge. When it comes to doing homework, they have used, and I'm going to borrow this from Julie Flygar, all of their spoons. In addition to the form and function of knowledge, so we've gone over, there's cognition, there's knowledge, and then there's also this concept of grounded cognition. And so there's a variety of different things that also are going to result in how my cognition is based in my memory bank. Have you ever walked outside on a winter day and it smelled like snow, but it wasn't snowing yet? And as soon as you have that smell, did a memory come? Something like maybe Christmas or Thanksgiving. That's an example of grounded cognition. It is taking your environment and all the things that you're exposed to, taking advantage of all of your senses to create knowledge associations, to reinforce memory. You saw earlier, or actually no, it's going to be future slides, but also Dr. Trotty had shown it, that individuals living with IH, they show up physically. They have very low absenteeism, but they have a hard time showing up mentally. If I'm physically somewhere, but cognitively unaware, I can't create grounded cognition because I'm unable to immerse myself, immerse all my senses, which is going to compromise my cognitive function and my ability to navigate. So the same as I had shared, that there are going to be these other senses that can bring a memory back to mind. If I'm unable to even recognize the other senses, those memories are not going to come. So to make it even more complex, an additional layer that influences cognition is actually personality. Many people who live with essential disorder of hypersomnolence have shared with me that they felt that their personalities had been robbed from them. Many parents of children who have essential disorder of hypersomnolence will tearfully express to me when they're adequately treated, "You've given me my child back," because they're smiling and have a personality. It makes me cheerful because it is not a simple thing to define. All of this gets robbed and layered, and we attempt to label it as a singular thing. So when you're looking at personality, why is this important? Because when we see personality, you can see that different types of personality can actually have a significant impact on your cognition. And what you're seeing here is individuals who are more conscientious as well as open are going to have a greater degree of ability to have higher functioning cognition. However, if you tend to be a little bit more neurotic, you actually have one of the lowest functioning. With that type of personality, it is going to be a higher degree of susceptibility when predictability has been taken away from me. I innately will become a little bit more neurotic if I don't know if I'll be awake enough to show up for the party, physically or mentally, to hold a job. And that is going to negatively impact my cognition. One of the things that have been starting to be studied is the fact that we're seeing a greater degree of emergence of neurodevelopmental divergence for individuals living with central disorders of hypersomnolence. And the question becomes, is it chicken or the egg? Is it the individual who has a genetic susceptibility to neurodivergence, or is it the central disorder of hypersomnolence who has impacted their neurodevelopmental trajectory to have more of a neurodivergent personality or phenotype? And so understanding that when we're starting from the basic framework of what does brain function look like, and that we've now said there's a personality component, there's a situational and grounded cognition, there is these other areas of executive function and memory and processing. You can see now we're trying to define the opposite of a pathology of brain function becomes really obtuse. So there has been the attempt of trying to create scales around brain fog and even seeing what are some of the common symptoms. And one of the biggest challenges when you're looking at the definition or these questions around brain fog is that they're really utilizing other symptomatology to define what brain fog is. And so you see terms like fatigue, worn out, sluggish, run down. And so are we defining brain fog using the definition of other disorders? And so again, these are giving you a little bit of a bubble chart to tell you about the different symptom experiences that people may have and things that may be contributing. And there even are things like somatic symptoms of dizziness and grogginess, headaches that are also going to further confound us. So there was a social media listening approach to really trying to understand and zero in on people living with hypersomnolence. There were 2 online sleep disorder communities, and it looked at over 355,000 posts and comments, and it applied something called natural language processing. It's a machine learning model. And they found about 5,000, a little over 5,000 brain fog related posts between 2011 and 2023. They identified some odds ratios of what was going to be the likelihood of a person having it, and then they did applied topic modeling. Part of the understanding of this, or part of the effort of doing this, was to also understand, since COVID, brain fog seemed to be a very popular term because of long COVID. And so there was also this question as to whether or not, has brain fog always existed? Did people talk about it beforehand? Or is it really now that it's just become sensationalized, a quote unquote Me Too movement of we all have brain fog? And is that the reason that we're seeing it? And that's the reason that it's so obtuse and difficult to experience. Before I go into that, I wanted to read. I do have my cell phone. I wanted to read because it was just such perfect timing. I was at a meeting before this and I get an alert from Reddit, and this is the alert I got. Someone had posted, "Brain fog is killing me. I wish it was just being sleepy and tired all the time. Chronic exhaustion is awful, but I could make peace with my condition if it was just that. But experiencing cognitive decline at 21 years old is a little too much for me to take. I don't feel understood, and I don't know if I ever could be understood. The only true sympathy I've been able to find is in older adults, people who are with age experiencing similar things to me. It's so painful that my experience is only relatable in people 2 to 3 times my age. This wasn't supposed to happen so soon. I'm worried that this is permanent. I can't speak as well. I can't think of words off the top of my head like I used to. I forget things that should be blatantly obvious. I showed up to my internship last week without my backpack, which contains the one thing I need, my laptop, to do my job. I was even thinking about browsing Pinterest on said laptop on my drive there, only to realize I'd spent 50 minutes driving somewhere I cannot do anything at all. I'm worse at my pharmacy job. I feel like I'm mourning my younger self, a self who never had the time to fully realize into herself. I feel so alone and hopeless and afraid that it will only get worse. We know next to nothing about this aspect of the disease, and the term brain fog isn't even in most medical literature about the condition. I'm at a complete loss of hope. I wanted to go to med school, but not bad enough as to where I could work through this. I want to get a PhD now, but I feel completely incompetent and incapable. I feel like an absolute dumb F word. Every single day, and it's growing impossible to not let it get to me. I was only diagnosed in February, but the drugs I've tried haven't helped the brain fog, and for different reasons, weren't great for alleviating EDS either. I'm in a long-winded process of trying to get another medication, but I'm so afraid that it won't help the brain fog like I've been desperately hoping it will. I don't know. I just wanted to scream into the void for a bit with this post. Writing, creating something, beats sleeping and having nothing to show for it. Not even some energy. I want my brain back. I want my life back. How many in this room can identify what I just read? Identify with that. I want you all to look around with your hands raised and see that you are not living this journey alone. And I also would encourage you all to speak to one another about what your life looks like with brain fog, because I guarantee you that none of your experiences are the same. There may be similarities, but they're not the same. Now, when looking at zeroing in on people who are living with hypersomnolence, what did we identify? It's a growing problem or just a growing discussion? I think what we're seeing is that people are starting to understand that they're not living this alone, but they're also doing exactly what I just read to you. They have nowhere else to turn to. They're being dismissed or invalidated in clinical settings. And what we are seeing now is that when you're looking from 2011, you can see that the term brain fog itself actually is exploding, despite us not having a definition for it. So when you're pulling it all together, what you're seeing is that brain fog did exist before COVID-19. However, there was still a substantial increase that even occurred before 2020. It has similarity to other disorders, but really a common theme was memory and attention difficulties. Distinctly, brain fog was also associated with sleep-related concepts that may be unique in hypersomnolence. So when looking at people who have idiopathic hypersomnia, there was much more of this overlap of how the excessive daytime sleepiness or sleep inertia really compounded their experience of living with brain fog. There's been a variety of attempts of trying to approximate this dysfunction in IH, and sometimes it's looking at things like the British Columbia Cognitive Complaints Inventory, and you're seeing that individuals, whether it's with or without long sleep time, are really describing that they're feeling as though that their cognition is greatly compromised. And as I had mentioned earlier, individuals with IH are more likely to show up, physically be there. So you can see that they have a much lower absenteeism than they do in regards to their presenteeism being compromised. But it overall is greatly impacting their activity. When you're looking at individuals who are living with or without long sleep time, again, you can see that a vast majority are experiencing these symptoms. And you can also see that it's not something that really goes away very easily. So on the right side of the slide, what you're seeing is that those who said about 83% who said, yes, I definitely experienced brain fog at my worst, but you're still seeing 54% describing that within the last 30 days that they were having the symptom at least daily. You're also finding that this isn't unique to just IH. We're seeing that it is occurring in IH, NT2, and NT1. When you're looking at the top part of the slide, what you're seeing is that NT1 at their worst maybe are experiencing it more commonly. However, when you're asking again the symptoms within the last 30 days while on treatment, it seems to be the most resistant in people who have IH. It's still highly prevalent in individuals who have IH. And again, that raises this question, is the brain fog being experienced in NT1, NT2 IH, even disorders who have similar faces? Is it the same brain fog? So how can we strategize for success? I did a whole long-winded talk on the fact that I gave you no definition of what this symptom is. So what can we do? Well, we can start with really setting clear goals. So even without a definition, you can still identify what is it that great looks like for you. So setting clear goals, acknowledge what your strengths and what your weaknesses or opportunities are. Identify what those mile markers are. What is your timeline? What are your milestones? And then seeking feedback. This isn't a journey you're taking alone. You're going to want to know, are others seeing the progress that you feel like you're making, or you feel like you're not making as much progress? Sometimes it's those around us who are identifying the changes that are occurring in us that we no longer appreciate, and then implement adjustments as you're going. So this really is a symptom where a transdisciplinary approach is necessary, and you need to consider the whole person. Neuropsychology, I think, is a really critical component of this. Although there is not a specific cognitive domain, understanding your particular cognitive domains that may be compromised can help to better personalize strategies to improve your brain function. Consider incorporating things like physical medicine and rehab, having PT, OT, speech therapy assessments. Some of these things can be very helpful because they can give you adaptions to meet you where you are. You don't need to do things like other people do. You don't even need to do things how you used to be able to do them. I used to be able to do cartwheels and fall into a split. Can't do that anymore. I made some adaptions. I just don't do cartwheels anymore. Psychology and psychotherapy, coping skills matter. We can become very resentful during this journey. And in fact, people can also develop the F word, frustration. And I strongly encourage people to abandon that word. And the reason why is because frustration, by definition, means it's an emotional response to something you can't influence or change. Every single one of you are sitting here today or watching online because you're looking for the things to influence or change your trajectory or your loved one's trajectory. So abandon the word frustrated because you're active in your own journey. Incorporate your other medical disciplines, understanding complementary management of other existing disorders. We've talked about the existence of other comorbidities can also contribute to having brain fog on their own. So maximally managing all those symptoms make a difference. Don't underestimate nutrition and exercise. These are key pillars. Get moving, utilizing food as medicine. And then what else makes you feel good? Just because there's not data to support it doesn't negate if it makes you feel good. One of my favorite quotes is by Carl Sagan, which is the absence of evidence is not the evidence of absence. If it is massage therapy, if it is Reiki, if it is meditation, do it. Don't let any doctor tell you that it doesn't work or there's not evidence to do it, so therefore you shouldn't. But always balance the risk benefit for you particularly. One of the things that can be very helpful when you're struggling with any type of cognitive challenge is effective time management strategies. And this is, I'm not going to read all of this, but these are things that are intentionally put in here so that you can utilize them at a different point in time. But it's helping you to understand prioritizing tasks, setting time limits to doing certain tasks, setting clear goals, learning to say no, and allowing for yourself to have those guardrails. I'm one to talk. I'm preaching something that I have a hard time with of saying no. Using a planner, reviewing your day, avoid multitasking, and taking regular breaks. In terms of mastering time utilization, some of the things you can do is prioritizing the tasks that are going to be urgent and important, and scheduling time blocks to do these. So I'm going to show you on the next slides how you can potentially do this. So one of the exercises I very frequently will tell my patients to do is I want you to do daily time utilization. And it's not just my hypersomnolence patients, it might be my patients who have migraine or epilepsy, who they're struggling for one reason or another. And the reason I ask them to do this is I ask them to be able to take into account every single thing they do in a day. Everything from eating, preparing meals, doing work, as well as their social media scrolling, and to keep a complete log of that, because that gives you an assessment of how you're spending your time. I then want you to take all of those items and then I want you to prioritize them to these different quadrants. What is urgent and important? What is non-urgent and important? What is urgent but elective? You don't really need to do it. And then what is non-urgent and elective? When you're doing this, you now can prioritize when you're spending your day doing each of these tasks. When you're also thinking about your day, you can look at, are there points of my day that I'm a better version of me? I'm your super morning lark. I know that my best version of me is in the morning time. In the evening time, I am not as quick as I would like to be. I'm not as creative as I would like to be. So the things that are most urgent and important, they're always scheduled for first thing in the morning. The things that are that elective and non-urgent, like my social media scrolling, that's going to be in that pink box. This allows you to be able to take control of the time that you have to be most functional. Some of the pharmacologic approaches for treatment of IH this is from a paper that I had published in 2023, was looking at a variety of these different types of symptom burdens. And it's important to recognize that although I included brain fog and cognitive complaints, this is based on some limited data that has demonstrated that there may be evidence here. You're going to see that lower sodium oxybate is listed in each of those because of the fact that it is the only FDA-approved medication, and it did demonstrate that it had very significant impact on its pivotal trial across all of those domains. One of the things that's unique about its indication versus narcolepsy's indication is in narcolepsy, it's indicated for excessive daytime sleepiness and cataplexy, although we know it benefits other areas. In idiopathic hypersomnia, it is indicated for the disorder because it holistically can benefit an individual living with idiopathic hypersomnia. Now, with that stated, it doesn't mean that that's the only treatment that can potentially benefit you. And so it is important for you to always be personalizing the therapy for what may make you more functional. And we did talk about just the treatments a moment ago. There also is a European study that has demonstrated a large randomized controlled trial that demonstrated twice nightly sodium oxybate may be beneficial for idiopathic hypersomnia, including things like brain fog. There's definitely directionally positive results from the pivotal trial that was done with pitolisant. It did not meet the endpoint, so it didn't get the indication. However, stay tuned because there's going to be, I think, newer versions that are going to be able to hopefully provide that benefit and that approval. We do see some benefit with modafinil, and there are some current studies looking at once nightly sodium oxybate, which I'm expecting to also provide similar in improvement, as well as having the duration that may be necessary, as well as orexin 2 agonists. So this is a promising time that we're seeing that there's approaches to treatment. However, it's important to know that although all these medications are being looked at or have been studied, there's no medications that have been specifically developed or studied specifically to manage brain fog alone. And so that's just an important distinction, is that we still are on that journey there. This is giving you the data, and I just want to demonstrate a couple of things that I think are important from this data from the twice nightly mixed salts or low sodium oxybate. So what you're looking at on the left side of the slide is really what the trial looked like. So this was a double-blind randomized withdrawal trial, and with that, it uses an enrichment design, meaning that the people who are allowed to participate are people who they got the drug, they used the drug, and they had benefit from it. If you didn't have benefit, you couldn't continue on into the study. Now, with that stated, my personal view of that is that it does give you an indication that these are likely people who had truly idiopathic hypersomnia, but they were not NT2, they were not IH. Now, with that stated, one of the other points that I think is important and also overlaps from the study that was done by Yves Davier in France for the randomized controlled trial is that by week 4, you see that there's almost complete symptom resolution as measured by the idiopathic hypersomnia severity scale and the Epworth sleepiness scale. Now, when you're looking at the part that the FDA approval comes in, it's in those colored areas because that's looking at how bad do you get when I remove the drug. And so a part of this design that is, I think, a very important one is that it, number one, is much more patient sensitive. All patients are getting medication, and it's limiting the amount of time that you're not on medication. Now, what you're seeing on the right side, however, is you are seeing the symptomatology and the improvement in the symptomatology. And you can see these are all the questions from the idiopathic hypersomnia severity scale, and you can see that they're all very significantly impacted in a positive trajectory, improving domains that would impact your cognitive function. So, in conclusions, you don't need a definition to define your lived experience with brain fog. You want to consider all aspects that contribute to your function. So we've talked about personality, we've talked about the different domains of cognition, your other sensory modalities that are going to influence that. You want to live empowered starting today by identifying your starting point. Set goals, team up and partner, and then measure the progress that you're making. It's not binary. It's not that I'm normal or abnormal. It's that I'm becoming a better version of me every day. My CEO gave me a quote that I love, and it's one that I hope that each of you take. He says, in our healthcare system, I don't want to be the best. I want to be the best at getting better every day. That's what I hope for you. And I want you to choose to be amazing and accept nothing less. Thank you.